Today's training is on advanced care planning and evaluation management time-based coding. This presentation was prepared by Pinnacle Healthcare Consulting. Pinnacle provides a broad range of strategic, financial, and operational services to law firms and healthcare organizations such as hospitals, health systems, ASCs, and medical practices. This presentation is for informational purposes only and was developed specifically for the use by Center for Improving Value in Healthcare. Pinnacle has prepared the presentation using official Centers for Medicare and Medicaid Services documents. While Pinnacle has made efforts to ensure the content of the presentation is accurate, Pinnacle makes no representation, warranty, or guarantee that this information is error-free or that the use of information within the presentation will prevent difference of opinion with payers. The ultimate responsibility for correctly using the coding system lies with the user. This presentation is copyrighted, and any unauthorized use may violate copyright, trademark, and other laws. Per the CPT codebook, codes 99497 and 99498 are used to report the face-to-face service between a physician or other qualified healthcare professional and a patient, family member, or surrogate in counseling and discussing advance directive with or without completing relevant legal forms. An advance directive is a document appointing an agent and/or recording the wishes of a patient pertaining to his or her medical treatment at a future time, should he or she lack decisional capacity at that time. Examples of written advance directives include, but are not limited to, healthcare proxy, durable power of attorney for healthcare, living will, and medical orders for life-sustaining treatment. It is important to remember that advanced care planning services are voluntary, and Medicare beneficiaries should be given a clear opportunity to decline such services. The Medicare beneficiary or their family members may choose to receive assistance in completing legal documents from outside the scope of the Medicare program. Appropriate documentation is the key when seeking reimbursement for advanced care planning services. The documentation should include an account of the discussion, the voluntary nature of the encounter, documentation indicating the explanation of advance directives, and when completed, the documentation should indicate that those forms were completed. Documentation should also include who was present and the time spent in the face-to-face encounter. Providers will want to check with their Medicare administrative contractor and private insurance payers regarding any specific documentation requirements. An advance directive does not have to be completed to bill advanced care planning services. The CPT code description indicates when performed. Therefore, completion of an advance directive is not a requirement for billing the service. If an advance directive is completed, documentation should indicate the completion of such forms. Per CPT and the Centers for Medicare and Medicaid Services, there is no limits on the number of times advanced care planning can be reported for a beneficiary in a given time period. But when the service is billed multiple times for a given beneficiary, it would be expected to see a documented change in the beneficiary's health status and/or wishes regarding his or her end-of-life care. Advanced care planning can be billed by physicians and non-physician practitioners whose scope of practice and Medicare benefit category indicates the service described by the CPT codes and who are authorized to independently bill Medicare for those services. There's no place of service limitations on advanced care planning, and the codes are separately payable to the billing physician or practitioner in both facility and non-facility settings. There are no specific diagnosis codes required to bill advanced care planning. It would be appropriate to report the condition for which you are counseling the beneficiary. Advanced care planning services may be billed on the same day as most evaluation and management services, Medicare annual wellness visit, during the same period as a transitional care management or chronic care management service, and within global surgical periods. A modifier may be appropriate to indicate a separately identifiable service. Advanced care planning is not billable on the same day as certain critical care services. Take a minute to read through the documentation of advanced care planning on your screen. Does this documentation support the billing of advanced care planning services? Yes, advanced care planning services are billable. The documentation includes the conversation that happened between the provider and patient, as well as the forms discussed. Time is also documented, which is required when billing advanced care planning. Let's look at another example. Take a minute to read through this example of advanced care planning documentation. Does it support the billing of the service? No, advanced care planning is not supported for billing purposes. Although the documentation includes who was at the discussion, what was discussed, forms reviewed, and the patient's wishes, time was not documented. Without the documentation of time, advanced care planning cannot be billed. Next, we're going to look at a few other examples of codes that can be or are billed based on time. There are two ways to select the appropriate level of an evaluation management code: key components or time-based. The key components of an evaluation management code are history, exam, and medical decision making. When evaluation management visit consists predominantly of counseling or coordination of care, the level of service can be coded based on time. As with all codes, medical necessity of the service is the overarching criteria for selection and payment of a CPT code. Counseling includes diagnostic results, impressions and/or recommended diagnostic studies, prognosis, risk and benefits of treatment options, instruction for treatment and/or follow-up, importance of compliance with chosen treatment options, risk factor reduction, and patient and family education. When counseling makes up more than 50% of the total time spent with the patient during an encounter, time can be used as the key factor in choosing a level of service. Documentation must include total time spent, the percentage of the time spent in counseling, and what was discussed in counseling. Here are two examples of evaluation and management service documentation. One of these services is not supported as billable based on time. Read through the examples and decide which one is not billable based on time. This service is not billable based on time. Although time is documented and greater than 50% of time was spent in counseling and coordination of care is indicated, the note does not include what was discussed with the patient. There is an indication of coordination of care, but this took place after the face-to-face visit. Prolonged services are also time-based codes. The prolonged services referenced on the next two slides can be billed when a physician provides prolonged service involving direct, face-to-face patient contact that is beyond the usual service. In the inpatient setting, face-to-face time includes time on the unit or floor as well as the time spent at the patient's bedside. Prolonged service for less than 30 minutes on a given date is not separately reportable. Documentation must include the threshold time plus the specific amount of time for the prolonged service. For example, documentation could say, in addition to the 25 minutes spent performing the visit, I spent 31 minutes of prolonged service coordinating the patient's trip to the ER. Prolonged service codes are selected based on the place of service. The two tables on this slide are examples of inpatient and outpatient prolonged service codes and time thresholds. A complete table of prolonged visit codes and threshold times can be found on the CMS MLN Matters Change Request number 5972. There are also two CPT codes that are billable for non-face-to-face services. These services are reportable when greater than 30 minutes are spent on non-face-to-face patient care activities, such as telephone time spent with the patient or authorized family member, extensive medical review prior to or subsequent of another primary face-to-face evaluation management service, family meetings at which the patient is not present, or extensive time spent in reviewing diagnostic studies. Non-face-to-face prolonged service codes should not be used with chronic care management or transition care management services. The care provided in non-face-to-face services must be related to an evaluation management service where face-to-face care did occur or will occur within a reasonable amount of time. And it must be related to ongoing patient management. Documentation for non-face-to-face prolonged services must include the actual time spent and the reason for the time spent. Extra time must be medically necessary relative to the patient's clinical condition. Non-face-to-face prolonged services do not have to occur on the same day as a face-to-face evaluation management service. If a non-face-to-face and a face-to-face service do occur on the same day, documentation should clearly distinguish the two services performed and the time spent in each service. This is the conclusion of today's presentation. Contact Pinnacle for all of your healthcare consulting needs. Thank you.